right? If our neurological system is not intact, we learned that about last week, right, with ALS and MS and Guillain-Barré. So we need an intact neurological system, and we need an intact musculoskeletal system. Bones, joints, muscles. So all of those are going to come up today. Okay, all of those are going to come up today. Let's start with fractures. Again, this is need to know for nursing, but you will not be asked to say, it was a linear fracture, right? I'm not going to ask you to say what type of fracture it is, but here's my takeaway as we talk about fractures today. Sometimes fractures are very minor, so the intervention we do is different than if it's more of a complete fracture, which goes all the way through. Any fracture that goes all the way through the bone is a complete fracture. Comminuted fractures, they require different interventions because then we have teeny tiny fragments that need a different intervention, and I'll talk about that today. Another one that's to be very, very mindful of, you know your patient has a compound, also called an open fracture. That means the fracture actually broke through the skin. So they're like the bone broke, you know, bones are very sharp when they break. That's why you don't give them to your dogs, right? Because they splinter and then they can damage their throat. These patients are higher at risk for infection because now you have open skin and the fracture is open to the outside. Anybody have any experience with broken bones? Not one person. Oh, okay. Not literally like no, are you serious? Not one person? Okay, there's like 5 hands going up. So, anybody want to share the bone they broke and how it was fixed?
I've broken a lot.
What kind of fixtures did you have for fractures? Did they put it in an immobilizer? Did they set it?
Yeah.
Surgery?
An immobilizer. I was supposed to have surgery, but like I was mid soccer season, I would have had to be out, and
So they used the immobilizer until it healed? Okay, that's one we'll talk about today. Victoria?
I've broken both my ankles, and I fractured my kneecap, and it was just all immobilizer.
No surgery?
Not yet.
Okay, not yet.
Probably on my knee.
Probably, right? Because it's causing other problems, right? Anybody else want to share? Yeah.
I broke my nose, so I had to have surgery.
No surgery, right? Okay, yeah, it's hard to put an immobilizer on a nose, right?
I've also broken every toe.
Did they put them in something or just immobilizers?
Well, they made me tape them because I had to play, and so
yeah.
it was like,
Nothing like a good buddy tape, right? Tape that toe next to the next toe or the finger, right? So that's what I do a lot with my kids. So immobilizers, and you probably covered a lot of this in foundations, but oftentimes immobilizers are used just to stabilize, right? The joint or the fracture. And it helps with the healing process. Bones usually take 4 to 6 weeks to heal. 4 to 6 weeks. That's like a healthy person with no compromise. And the immobilization is for pain control. It helps stabilize the joint. It provides a lot of comfort.
So is a cast considered an immobilizer?
Yeah, because you can. We're going to talk about close reduction to fix with close reduction, and then you put a cast on it, and there's no surgery involved in that. So you can do a close reduction and fit it with a cast. So one of the main things, there's a section in your reading talking about cast care, right? And so a lot of the times, we don't want to get it wet. I think you guys talked about this in foundations, right? You want to elevate the extremity. You can use ice to help with swelling. Because what we don't want to happen is swelling underneath any of these or an immobilizer that's too tight. So one of the key nursing interventions with any immobilizer is to check a neurovascular assessment. So we have 7 P's for this. Did we cover the 7 P's in this class already? So let's review what those are.
Pain.
Absolutely. So are they having any pain? Pain should be expected, but a little bit depending on the fracture, right? If it's changing, right, that would be important. I heard pallor, right? So we're going to look at the color. You should still have normal cap refill. When I think of this, I also think of, well, that's for perfusion and pulse. I won't put it here. Okay. So what's the color? Right, it shouldn't be dusky. What else?
Pulse.
Pulse, yes. If I can stress anything for this whole lecture, it's make sure you have perfusion. P-E-R-F-U-S. Right? Cap refill. Sometimes these are hard to get to. You know what I mean? Like, I can't assess really pulses here, but I can still assess a lot of circulation. Right? I can the color. So polar temp. Yes, edema. For almost every fracture or immobility thing, I usually see a little bit of swelling just in the area. But if the swelling then is cutting off circulation, that's why we have to monitor all of these things kind of at the same time, right? What else did we forget? Paresthesia, yes. What would a patient say to you if they were experiencing paresthesia? Right, I can't feel my finger or numbness and tingling. So they may not tell you that, so you touch this. Can you feel me touching your toes? Right, you have to elicit that response sometimes. We got 6. Yes. Can you wiggle your toes for me? So if you get too much edema, it can cause a compression on the nerves, right? So then you can have paralysis, paresthesia, and it can then decrease your perfusion. Okay, good. You have to know those 7. You absolutely have to know the 7. Okay, so let's talk about fracture repair. Closed reduction. Anytime something is closed reduction, that means they didn't have to open the skin. So there was no surgery involved. So you can align the bone without surgery. Usually this is done with manipulation. I mean, the patient may have surgery in the sense of they're not going to open the skin, but if it's a complicated one, they may give them some sedation to then reset the bone. So it sets and aligns the broken bone without cutting open the skin. And this is best done as soon as possible. As soon as you can, you try to do closed reduction. If the bone is in alignment, right, you'd have to have a pretty clean cut, right, to align it. Like if this was just slightly off, you could align this. But if it's twisted or comminuted, right, it would be very difficult to do a closed reduction surgery. Okay. Cast care, I talked about that a little on the last slide. You can elevate the affected area. You can put ice on it. But the main complication is if that extremity gets pale or cool or swollen, it's gonna impair circulation to the tissue. So you gotta control that swelling. Elevation and ice usually do a pretty good job with that. Anti-inflammatories. Okay, traction. Have you seen traction before in the hospital? It's a system of weight and pulleys to keep the joint elongated, right? Because when you sometimes fracture a bone or fracture a hip and it's misaligned, then the muscles will all kind of shrink up and the tendons and everything, so you want to keep everything in alignment. Traction is usually used for knees, hips, big joints that are broken. In my experience with traction, it's usually before surgery, so they're waiting to have surgery, but maybe we got to fix some other things first. I've also seen it used as palliative care for patients who are really, really, really old and they've broken a hip, but they're not a candidate for surgery, and so you'll put them in traction until kind of the bone heals a little bit enough on its own. Usually they're going to be immobile anyway for the rest of their life, so it's a comfort thing. I've seen it used for that too. External fixation. So this is an external fixator. So they obviously had surgery, right? And the bones were either so fractured or they weren't able to align it and then put hardware in, for whatever reason, and you have to have external fixation. So this requires a little bit more nursing care because now you have pins out and an incision outside the body. So you're going to have to monitor that site really closely for infection, swelling. It really helps with proper alignment. And ORIF is an open reduction, internal fixation. So it's opposite of closed reduction. This is an open reduction, internal fixation, which is what's going on up here in these pictures. So open, meaning they opened the scan and then they did an internal fixation of the bone with hardware. There's an x-ray you can see with pins and screws, but they're not going to have anything on the outside. You'll just have a surgical incision to take care of. Questions with those repairs? Okay. Let's talk about complications. The main one from here that I want you to pay attention to would be the first one and the last one. Okay, so the other ones are good to know as a nurse, but don't start quizzing each other on the other terms, okay? So when we break a bone, we can actually, like little pieces of fat can get into our vascular system when blood vessels are broken as well. And a fat emboli is one of the biggest complications of fractures. A fat emboli. The fat comes from the bone marrow and it goes in and into the bloodstream. So it's going to act like a venous thromboembolism, right? It's just not a blood clot. So they're at risk for a PE as well. So when you have a big fractured bone, know that they could get a fat emboli, which is just like a blood embolus, and it can travel to their lung. So they're at high risk for that. So monitor for that. There's not anything, you can't put them on blood thinners for that. It's a fat emboli, right? It's not like you can, it's different. We just need to monitor for it, okay? And early intervention if possible. They become shortness of breath, restless, low O2 sats. All of that would indicate a pulmonary emboli from the fat embolus. Does that make sense to everybody? Have that? Okay. I know it's Monday and it's get post-holiday brain. All right. Then other complications that can happen is avascular necrosis. What do you think that is?
Outside of
No blood flow, basically, right? So A is the opposite, avascular necrosis. We've heard necrosis before. This is the same as a bone infarct, like a heart attack. Bones require vascularization, right? But if you have a large fracture, you can actually have bone death, right? So that's avascular necrosis if you don't have good blood flow to that bone. It's a bone, it's like a heart attack for your bone, right? Delayed union. This is when bone takes longer to heal. It usually happens from inadequate blood supply or infection. So when you think about the hardware you just saw, or any fracture repair or a cast, and their bone just not healing, so they're going to take a series of x-rays to make sure, right, especially before you take a cast off, right? You usually get another x-ray to make sure it's healing.
You said it was from what?
Infection, or they don't have enough blood flow to that area to heal the bone. Those are the two main reasons we see delayed union. This is common, not common, I say common only because I've seen it, but when people have heart surgery, you know, we open the bone for a sternotomy to open their sternum for open heart surgery. Well, older patients who have other comorbidities like diabetes, so they may be overweight, they are high risk for infection, and they have delayed wound healing of their sternum often. Wound infection, that's pretty obvious. So you'll monitor for things that how would you know your wound's infected? What would the patient look like?
redness around the incision.
Yep, like excessive. A little bit of redness post-surgery, normal finding. Little bit, right? But if it's a lot, the wound could be infected. What else would we see?
Discharge.
You might see drainage, like serosanguinous should be good, right? Even a little sanguinous right after surgery, fine. Not copious amounts, right? But if we get this yellow or green tint, kind of purulent drainage, right? That would be an infection. What else would we see? I'm looking for 2 more things. Temperature. If you've got an elevation of temperature, be suspicious. Not, maybe with cellulitis. I'm thinking of one more thing. We can see if they have an infection.
Pain? We can't see that.
I mean, they would complain of pain though. What else? Yes, which ones? White blood cells. Yes. They may bump their white blood cells up. Absolutely. And one thing we'll talk about Wednesday is banded neutrophils. You guys talked about banded neutrophils. Those are immature. So if you have an infection, then an acute infection, and you use up all your neutrophils, right? Then you get the immature ones out in circulation. That means you have an acute infection. So wound infection, osteomyelitis. This is a bone infection. It's rare but serious. We see that with gangrene a lot too, osteomyelitis, because then the infection gets into the bone. Failed hardware. Some people just don't like the material in the hardware, right? And so they have failed hardware. And then the other one I really want you to know, have you talked about acute compartment syndrome yet? Not in maternal child? Okay. So acute compartment syndrome, do you see that? So this would be a cross section of, let's say, your thigh. And you've got a bone here. Oh, this would be your lower leg because we have these 2 here. So you have these blue lines, and these are sections of our muscles that are surrounded by fascia or connective tissue, and these are compartments within. So you have multiple compartments. Do you see that? So when we have sometimes a fracture and you have tissue trauma, let's say this bone breaks and it starts swelling in these 2 compartments, and you have a rush of blood flow, muscle swelling, that sort of thing, you can get so much swelling in this area that it starts to completely compress your circulatory system and your nervous system, to the point it can threaten your limb. Like your limb could die. So it's called acute compartment syndrome. It's increased pressure within one of the body's anatomical compartments, and it results in reduced blood flow. This is an emergency, so you will see swelling, rapid swelling. So if you know that there's a crush injury, fracture, muscle injury in the area, and you have rapid swelling, and then you see the extremity getting dusky and no pulse, and you get a lot of these P's, like 8 of them? No, there's only 7. This is an emergency, and it requires a surgical intervention called a fasciotomy. And that's what you see this illustration. It's a fasciotomy. I've seen this done at the bedside. Sometimes we can get them to surgery. We've certainly done them in the ER. So you clean the skin, and you take a scalpel, and you release pressure, right? So you're just cutting through the sub-Q down to that compartment. Not you. Let a doctor do this, please. She told me I could do it. You could. I mean, if you had to, right? I always think, like, could I trick someone if I had to? Maybe. I don't know. You just want to relieve pressure. Once the pressure is relieved, guess what? You've taken the pressure off of the blood vessels, right? There's no damage there, and you should have good perfusion. And then we just treat this like an open wound. So then with the fasciotomy, we treat it like we're going to usually put some saline gauze in there and keep it covered until the swelling goes down. Usually when the swelling goes down, sometimes we can go back and then close this. I mean, we're talking it takes days, right? So you have an open wound that you have to change and keep moist, but sometimes we just have to heal it by secondary intention, where you just keep packing it until the tissue regranulates. Okay, that's too much to know for the test, but for life, you'll need to know it, right? Because it's very threatening to the limb. It can happen in the upper extremities as well. With fractures, usually we just see these in the extremities happening. But because we're talking about mobility today, one of these injuries in our lower legs affects mobility much more than if we had an issue with our upper extremities. Okay. So let's look at a case study. Mr. Smith is a 36-year-old male patient in the ER following a traumatic injury to his right leg. Look this gnarly x-ray. So the x-ray shows it's an open compound spiral fracture. Do you see how this goes all the way through, but around, but down, and to the right? I mean, you know what I mean? It's like all over the place. Both bones are broken, right, all the way through. It's not straight across, so spiral fracture. And then we just know from his injuries coming to the ER, it is an open fracture, so it broke through the skin. This is his right tibia and fibula, right? You can see that lower extremity there. The EMS has immobilized it. The right lower extremity. Gauze is covering our wound. And then let's take a look at his vitals. Okay, you've just received the patient. You're standing in the ER, and this patient comes in, and he's got an immobilized right lower extremity, so they've put splints on it or something, I'm assuming, on the sides. And then there's gauze covering the wound, and the EMT has just told you what his vitals are. What's the first thing you're going to do for that patient?
Pain.
No. And I only say it intensely because I want you to get this. No. 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 Perfusion. Doing what? How are you going to assess it?
Capillaries?
Pulse. Pulse. I need to know if that foot is getting blood. Right? That's the very first thing. Right? Airway, breathing, done. Patient's alive. I can see with the vitals, right? Circulation. Perfusion. I'm going to walk in and I'm getting a report from that EMT who's bringing him in, and my hand is on the foot. Because what if I gave him something for pain? Think about, that's like a 20-minute, 10-minute process. In the ER, you can get things really quick. Okay, 5 minutes, maybe 5 minutes, and I've got him. Now I'm assessing pain. Now I'm assessing doing other things. All the while, the foot's dying. You see what I mean? We're going to lose that leg if I don't have circulation. I know he's alert and whatever, and I know he's having pain. I'm going to get to that. But once I know he has perfusion, I'm going to move to the other things. Okay? Perfusion. Check the pulse. That's it. Lecture over. Drop the mic. Okay. No, I'm just kidding. What is the nurse's priority? So that's the priority assessment. And then what's the priority intervention? You guys said it. Pain. Right? We're at 8 out of 10. Please tell me if I broke my bone and it looked like that, you would knock me out. Right? You would give me the good stuff. Right? So perfusion that's my first assessment. Now my first intervention for him that's already immobilized. If it wasn't immobilized, I'd probably want it immobilized. And I'd want to cover the wound, right? But let's make him comfortable. Let's make him comfortable. Okay. You're all thinking on the right track, but I want to shift your brains to, if I don't assess the pulse, that foot could die if I do 20 things before that. Okay? So Mr. Smith had a successful surgery with multiple plates, pins, and an external fixator placed. This is impressive, right? Your morning assessment. So now he's had surgery and you're now working on med surg. You're all over the place. You're an ER nurse one day and now you're a med surg nurse. 7 P's. Make sure you know what normal would look like. He should be warm, moving his toes, good pulse, right? The drainage around these sites, maybe mild redness, maybe sanguinous or sanguinous is okay, a little tiny bit, but there should be no infection to these sites, okay? What complication is he at most risk for? Fat embolism, we're going to always in the back of our head think if he gets short of breath or something, that's my first go-to, yeah? Infection is the other thing, very high risk for infection. Yeah. What else? Maybe. He could be also at risk for a regular DVT, because he's not moving this foot at all. And I can't put a TED or an SCD on it, right? So he'll probably be on like Lovenox or something to prevent him getting a blood clot. Yeah, it's a big, complicated surgery.
Do we need to know what of those would be highest that we worried about?
No. At this point, it's kind of everything all at the same time. Once you've done your 7 Ps in your assessment and you're comfortable with the neurovascular assessment of his extremity, just be mindful all those other things are, it's not an actual problem, they're all potentials. Yeah. Good. Okay, now it's post-op day 3. 3 days post-op, and your morning assessment. Let's take a look at those vitals. You already know it's not going to be a good day, right? Like this, the right foot's cool. Patient's not able to move the right foot. Pulses are 1+, and he has blackened skin with blisters. You just made this assessment. What's your next thing you're gonna do?
Maybe see if you can find the pulse in the foot with the Doppler.
You can find it. Pulse is 1+. You've got circulation.
Give oxygen.
CBC for infection.
You can't do that without who?
Probably gonna call someone.
You're gonna call somebody. Who's gonna call? Right. I know. I wanted to see the new Ghostbusters movie, but I haven't seen it yet. Right. This, if I came on and I've got a 102 and this blood pressure and this pain and a cool foot and not able to move is huge. Like I'm dialing and I'm dialing and walking, right? This is an emergency, right? This is an emergency. You must call the doctor, but yes, he will probably get, right, blood cultures. He will probably get the whole panel of blood work, right? And he's probably going to come see you first on rounds. So that would be fantastic. All right. The big reveal. This is a true story. This is a true story of Alex Smith, who is a football player, who was treated for compartment syndrome. That's what was happening. And necrotizing fasciitis. Necrotizing fasciitis is a flesh-eating bacteria that he got in his skin. And it caused him to lose, this is an actual picture of his leg after multiple surgeries. These are actually his too. This one, not this one. That's his actual fracture. Thank God for the internet, right? And he lost the interior compartment of his right lower leg, and he had to have multiple muscle transplants and skin grafts. They took it from his left quadricep muscle. He remained in an external fixator for 8 months, 17 surgeries, and 4 hospital stays. He actually played football again. So he trained almost for a year with veterans who had big injuries and did some intense training, and he had this apparatus thing that he wore on his lower leg. But you can actually see his fracture. This is his foot when it went down. I mean, you can't see the fracture, but this is what his foot looked like. I don't know who that photographer, that's actually him, Alex Smith. So he twisted and he was pushed down. So now you can see how his fracture occurred.
Where do you think the fasciitis came from? Does it come from surgical?
Necrotizing fasciitis, I don't know, and it never said in any of that. I pulled multiple articles and I watched a great like 2020 special or something on him where they went through his whole journey, because he got deathly ill with infection multiple times.
After surgery?
It could have been from, in my expertise, it could have been from the open fracture, because it did open. There was like pieces of his sock, like to his bone, like on the outside of the bone. But it could have just been in surgery too, something he picked up, a hospital infection or something. So it's pretty gnarly. Okay, and that is why it's important to do good nursing assessment, because you can catch this stuff early and save a leg. All right, that's just a little drama. That was pretty drama. A lot of drama. Okay, amputation. Let's talk about amputations. So in the realm of mobility, if anybody requires an amputation, the goal for treatment is to take as little of the leg as possible, because the more leg that has to be removed, the more it impairs mobility. So that's usually the goal. Amputations happen from trauma, medical illness. We know with diabetes, sometimes we see amputations. Peripheral arterial disease, it's another big one where we see amputations. They don't have good perfusion. Again, we see amputations in upper extremities, but in the concept of mobility, right, it's going to impair more if it's a lower extremity. Some things to assess with amputations: pain. And we're assessing pain not only in someone who's had an acute amputation, but somebody who's had an amputation for a long time, because we're looking at phantom pain from our pain lecture, right? They may be living with chronic pain. And then psychological trauma. Has anybody had an opportunity to take care of a patient with an amputee? Yeah, a few head nods. Yeah. New or old? New? From what? Do you remember?
He had diabetes and then didn't take care of one of his toes and had his foot amputated.
Did they take it like at the ankle or?
Yeah.
Yeah.
I had the same thing, but it was old.
He had it for a long time. Yeah. Yeah. Or they had it. Yeah. So with a new surgical amputation, you're going to be managing the surgical wound and the musculoskeletal pain as well. But still assess the stump, even if it's chronic, and ask the patient if anything has changed or if it looks how it always looks, those sorts of things. The most traumatic amputation I'd ever taken care of was a police officer, and he had stopped over to help somebody on the side of the road, and another car hit him against the other car, and it was a traumatic double amputation. And it was so high up, we tried to save as much as we could, but once you get an amputation really high up, you don't have a lot of skin to pull over the end to make the stump. And so we tried skin grafting. I was doing the surgery, but I took care of him at the bedside. Multiple skin grafts from other places of his body to try to get skin to maximize the amount that he needed. And one of his amputations was so high up. I mean, it was really, really challenging to care for him. And he stayed with us for, I want to say, almost 4 weeks. And then his wound care was just so hard to manage. We actually had to transfer him to a larger facility that managed wound care because we couldn't get those enough skin to get closure on his amputations. He had multiple surgeries. It was pretty traumatic. That was the first time I lost trust in the news because people will report things that happen on the news, and then I was literally taking care of the patient, and I'm like, none of that is even true. Like, what the news was sensationalizing it about what had happened to this gentleman, and I'm like, they also say whatever they want just to get ratings, right? So
Did
I even
find the person that did it?
I don't know. But that was a long time ago. That's probably 20, 25 years ago, maybe. And I've seen a lot of amputations, but that was a lot of nursing care. All right, let's talk about joints a little bit, and as far as it's related to mobility. Osteoarthritis. This is a non-inflammatory disease. We're going to talk about rheumatoid arthritis for the last exam. That's an inflammatory joint disease. This is a non-inflammatory disease. You've probably heard the other name for osteoarthritis called degenerative joint disease, DJD. Sometimes you'll see that in a patient's health history, degenerative joint disease. This is caused by gradual, progressive, degenerative changes. Gradual, progressive, degenerative changes. So it usually affects weight-bearing joints, like hips and knees, sometimes the back. And then these changes lead to pain and swelling and reduced mobility of the joint. So probably everybody in here probably knows somebody. It usually happens for older people where they have a bad knee, right? Or they have a bad hip. And it's probably from these degenerative changes. Just as we age, the people at risk for this is usually people who are older or people who do a lot of weight-bearing activities.
What part of the body does it usually affect?
It's hips and knees and back. Like anything that bears weight, those joints will be affected. So the cartilage begins to break down, right? People have like meniscus changes, bone spurs, some exposed bone. So this could be knees and hips. And so the way that we replace them is usually with hardware. So you can have a total knee arthroplasty or a total hip. Total knee or total hip. mean, these patients now had bone surgery. They scraped some bone down, right? Anytime bone is interrupted, also think they're at risk for a fat emboli, right? Because you've kind of scraped down and exposed that bone. Anybody maybe going into orthopedics? Oh, okay. Good luck to all the grandparents out there who need, they need nurses too. We need nurses too. Oh my gosh.
Would that
Yeah, go ahead.
Would that just be like post-operative care? Or are you talking, like, I guess I don't even know enough.
For what? Post-operative care for what?
If you're going to orthopedic, like as a nurse.
Yeah, there's a whole floor. It's an orthopedic floor where you just take care of hips and knees and joints and people with surgery, right? Some hospitals have just orthopedic floors. Yeah.
I think I'm doing an externship on the OR trauma floor at least.
Oh, you'll probably see some there. Yeah.
She said you probably see a lot of that.
Yeah. So, like, a general medical surgical floor will take hips and knees, but sometimes orthopedic doctors, if they're lucky enough, they can have an entire unit of clean hips and knees. And what I mean by that is they didn't have an infection, or, you know, they came in for a planned surgery, right? And everything should be good. The thing is that you have an open wound and exposure to bone, so they are at risk for infection and hardware. They can reject this hardware. So orthopedic doctors get very, very protective of their clean patients. Now, I could have, let's say I had a respiratory infection, but I broke my hip. I need surgery, but I also have an infection. So that puts me at higher risk for this having a problem. And so orthopedic surgeons also don't want me taking care of this MRSA patient and then going into the next room and taking care of their new hip. So they don't like those to be mixed. So if they can at hospitals, they will just have a clean unit so that you don't have post-op complications where we're transferring stuff to everybody. One of the things for hips, the reason why, now not every facility has these, but these are abductor pillows, and it keeps the hips in alignment so the patient doesn't cross their legs. Right? So when we have a hip repair, apparently when you cross your leg, I guess this thing can come out, this hip can come out. I don't know how it happens, but that's one of the big nursing care things that's drilled into our heads. And there's a whole table in your book about post-hip and how to get them in the car and they don't cross their legs and how they're supposed to sleep and all that kind of stuff. But remember, if you don't have an abductor pillow, you can also just put a pillow between their knees to remind them not to cross their legs, like if they're sitting in the chair or in bed. Okay? We don't want them to cross their legs. Let me see if there's anything else on my notes I want to share. Never cross the legs. Oh, remember our pain management for non-surgical management of this. So if they are not ready for surgery, we can do a lot of things, right? NSAIDs are very helpful for this type of pain. A topical. So maybe if you guys have patients who need lidocaine patches on their back, they've got lower back pain or knee pain, hip pain, you put the lidocaine patch right on that area. A lot of over-the-counter creams, you know, like you rub it on, you know, like Voltaren, right. There used to be a cream called Bengay. A lot of older people probably know that one, but yeah. A lot of things you can use topically to help with discomfort. So over-the-counter creams, NSAIDs, COX-2 inhibitors like it's called Celebrex, but it's Celecoxib, XIB, CELECOXIB. Yeah, thank you. You should teach pharmacology. I will not be teaching pharmacology. That would be the bottom one for me. Mainly because I just can't pronounce them. I don't mind the content, but we should just have like a touch screen where it just pronounces it when you want it to say it.
Bone was really good at it.
I know, and she's leaving, so for shame on her.
Did you guys get a new teacher?
No. We don't get more people. We don't get more people. We have somebody who's teaching that class, but they're already working here, so we'll just get creative. Common symptoms associated with altered mobility. All right? I'll let you just read through those. It's pretty obvious. Any questions on those? They're all fall risk. Fall risk, fall risk. All right, let's talk about treatment then. Most patients with fractures or amputations are going to require some sort of physical therapy. We've got lots of pharmacological therapies that we can do. Don't forget about nutritional supplements too that will help with bone healing. So increasing maybe calcium and vitamin D. We have options for surgical immobilization and then assistive devices as well. Canes, walkers, right? Anything they need to increase mobility. We really don't want them bed rest. Like bed rest is like one of the worst things because there's so many complications when people don't get out of bed. Urinary tract infections, pneumonia, all that stuff. Blood clots, bed sores. We got to move them. All right, any questions on this slide? Don't forget about non-farm. We talked about repositioning, those sorts of things for discomfort and pain. Heat pads, cool pads. Weight control is another thing. I mean, it's not going to be like overnight, but for people who are having really severe degenerative joint issues, sometimes just losing 5-10 pounds relieves some of that pressure off of their knees and their back and hips. So sometimes weight control might be one of the discharge teaching topics. So when we talk about bones, some things that the book talks about for diagnostics is obviously imaging. X-ray usually gives us a pretty clear image. All right, is anybody following this guy on TikTok where he'll show you a fracture, but then like the arm's off the patient? No? Okay, so he'll say like, do you see what's wrong with this thing? He goes, clearly there's a fracture here and here and here. And then he'll say, oh, and did you see that and they're usually wild. They're usually wild x-rays, but he's showing you something small on it, like, look at this little fracture right here. But then the whole arm is off the patient, so it's supposed to be humorous, I guess. So, funny. X-ray, serum calcium. So we can check serum calcium and serum phosphorus. Probably a little bit on both sides. So when we talk about screening, like if they're at risk for bone issues, if these are low, right, because these are the two that really deal with our forming bone, and we regenerate all of our bone all the time. So if they're low, you want to supplement with something. So that would be more of a screening. But let's just say I am taking care of that patient who had the fractures, Alex Smith, and I check his serum calcium and phosphorus. I would expect them to be high, circulating in his blood after that, because his body is actually repairing bone. So when our body is repairing bone, we get this kind of surge of serum calcium and phosphorus in our blood. So that would be expected. That wouldn't even be abnormal postoperatively. And then remember the enzyme, the cardiac enzyme, CKMB, that we talked about with a heart attack? That's a cardiac enzyme when the cardiac muscle is damaged. When skeletal muscle is damaged, you will have an increase of creatine kinase, which is CKMM. Questions? Okay. let's talk about primary prevention for clinical management. How do we prevent all these things from happening, right? Regular physical activity, protect against injury, optimal nutrition. So if you've screened somebody and they're at risk for their bone breaking or their hip breaking, right? Fall prevention measures, optimal body weight, rest. So how do we prevent complications from mobility? Think of Mr. Smith, our patient who's completely immobile. I want you to pair up. Actually, we need to get in groups of 7. So get in groups of 7 real quick. And we're each going to take a body system.